right, good morning, everybody. Wave your hands if you can hear us. Okay, stand up and turn around in a clockwise manner once if you can hear us. No, okay, that's not going to work. Can we ask you to mute your mics so that we don't get a bunch of feedback and things as we go through? It's a bit difficult to hear, to know if you got questions as you go through, but wave and we'll try to pay attention to it or jump in as we go through. If there's something that you're burning to ask as we work through, that would be great. Or we can do a bunch of questions at the end because there's a lot of sites that are on. So I don't know if you're looking at the PowerPoint thing or my ugly mug, the PowerPoint thing. PowerPoint thing, okay. I'm Andrew MacPherson. I'm an emerge doc. I'm one of the local medical guys for BC Ambulance in Victoria. And in the room with me is...
Jim Goulding, Regional Director for the fabulous Vancouver Island area.
And John Deakin, Paramedic Practice Leader for BCEHS.
Okay, so welcome, thanks for coming. So we're going to go through some stuff about Excited Delirium, but really this is about the ketamine pilot project that was running through Victoria over the last couple of months and a bit of an update on there, and then some plans moving forward for the whole province. So hopefully this is mostly educational and perhaps a little bit fun as we go through. Our agenda today is to talk a little bit about the background of what this Excited Delirium thing is. I pulled cocaine just as an example of sort of stimulant physiology, so we have a good understanding of what this really is physiologically out in the street. And then we'll move to a bit of a proof of concept about ketamine for this particular patient population, and then talk about the trial results for here in Victoria. And then after that, open it up to what's happening through the rest of the province and get a chance for questions as we work our way through, okay? So faculty, we always put this at the beginning. None of us make any money apart from within our little stipend with BCEHS, no consulting fees. I don't have any money in ketamine or in the needles that supply them. So there's no disclosure, no financial support that we're getting through this. Thought we'd start with a definition. There's a couple of them out there, but for purposes of this talk, we'll use this one. Excited delirium syndrome is a unique syndrome that's the presence of distinct group of clinical and behavioral characteristics recognized in the pre-mortem state. So this isn't the personality disordered guy that's a jerk, okay? This is somebody who's pain intolerant, tachycardic, sweaty, that you get near them and they're hot, they're radiating heat. They often seem to be fixated on mirrors and flashy things, especially with some of the other drugs besides cocaine. They're often agitated, they don't want to follow the police's instructions. There's often reports of them with superhuman strength. The way to think of this is you're out in the woods and you're trying to capture a bear and you can't negotiate with the bear. That's a person, if you start to try to capture that bear, the bear becomes very rabid and it gets to a point that you obviously can't negotiate with them, and their strength becomes rage as they get stronger and more angry. And it becomes an adrenergic overdrive. This is the population we're kind of looking at. It's a big deal, and it has been a big deal. You may remember this from the news a little while ago. There's a guy named Nathaniel who was bouncing back and forth in the middle of a highway after using cocaine. There's cars swerving all over the police. The police came to try to restrain him, and there's two more officers around the side. They ended up putting him down on his face and trying to hold him and stop him from jumping into oncoming traffic, and he died. So there was days of riots in Cincinnati after this because it was primarily a police problem 15 years ago. And the police got into a fair amount of trouble with it because they were charged with killing people. It's not the police, we'll get into that in a second, but it's the nature of this excited delirium. We need a different system rather than, just hold them down and figure it out. If you go back to the history of this, some of the best descriptions come from the American Journal of Insanity. Now, you're not allowed to call it insanity anymore. That's not a real thing. But in 1849, back when we lived in New Caledonia, and Hudson Bay Company was in charge of all of Vancouver Island, but there was a mental health facility in Winnipeg that had this great list of psychiatric patients, true psychiatric patients, so mania, schizophrenia, that didn't really have any drugs. They're not high on things. And their descriptions of agitated delirium or excited delirium there are spectacular. There's somebody who's very poetic in writing them down. So it's been around for a while. It's not necessarily drug related. It can be pure psychiatric. If you go back and look through, so in 1985, people started to realize cocaine and deaths probably was a combination here. So the first real publications are back here about whatever that is, 30 years ago. A couple of people died in police custody. So this dude named Ray said, maybe it's because the police are holding them down. Maybe this is a bad idea. So he took 10 strong, healthy volunteers had them exercise and work for a while, and while they were right after they worked out, lay them down on their belly to see if their oxygen saturations changed. They didn't. So he said, oh, well, there's no change in physiology after you've been working out, so holding people down doesn't have any effect. There was no change around hypoventilation or positional asphyxia, and then those whopping 10 volunteers were used in a couple of cases, and the police all of a sudden said, well, it seems pretty safe. And they were kind of given a green light to, we should just hold them down, because Dr. Reyes studied 10 people, and their oxygen saturations didn't change when you lie them prone. This is not the patient population that he should have been studying, right? This is cocaine-induced, hyper-agitated, pH is 6.9 guys that are breathing at 50 that need that respiratory rate to stay alive. And that one study was probably disastrous for 10 years worth of police intervention with these folks. And rather than going down the police route, we should have done what we are doing now, which is go down the medical route. Those takedowns started, they're often very physical, and you've seen multiple things for them. You can't talk them down. It's usually just hold them down, tie them down. There was hog ties, there was choke holds. And then they started to work through and realize there's an awful lot of police that are killing people. So there's 30 deaths, the role of restraints played a role. 98, there's a couple of other studies that came through. The reason I do this is just because there's some information we can learn about who are the higher risk in that period of time, and we'll touch on that briefly. So it's not the police's fault. This is a result of the physiology that's in the background. So in Canada, the prone restraint, still a bad idea. We don't move it. But it gives us, as I was just saying in that segue, research into the common features of who they are. What are the populations that are at risk of this sort of condition? 210 people died. This is a study about 15 years ago. It's a high proportion of people with stimulant use. They also have a high proportion of chronic disease. Remember, these are usually young people, and a good half of them that were passing away proximal to restraint were asthmatic or diabetic or had some sort of cardiac disease. It's also associated with obesity, which is probably something about PANIS and ability to ventilate easy. And when you put them in some sort of restraint position, your ability to ventilate is difficult. So the other thing we got from there is they're usually black, usually male, usually younger. That's probably not so much physiology as it is a commentary on United States access to illicit drugs or what a socioeconomic situation for that population is. And again, that's this same second review. High BMIs, more common in summer months, and that's kind of neat because there's that hyperthermic piece. People are often hot, and the ambient conditions and the ambient temperature adds to that increased risk of their hyperthermic piece that goes with it. So the greatest risk of death in police intervention is not if the person's an idiot, not if they're armed, unless perhaps... No, I won't go into politics right now, but it's if there's an excited delirium picture with them, okay? And we've sort of talked about what those features look like. When you do lie them down, here's kind of the physiology as we sort of alluded to. There was another study where Chan repeated that same thing, but it had a more specific, as opposed to just using O2 sat, looked at ability to ventilate. And it drops your FVC by 13%, and your voluntary ventilation can drop by 23%. This is the people that they're using 100% of their pulmonary system to keep their pH just above lethality. And dropping them that 15 to 20% is the end of them. So we need to be careful of that. That's the population we're worried about. Hey, let's talk about cocaine. That sounds like fun. So Sigmund Freud used it in 1884 to treat opioids. We're not doing that now, but I guess that's the situation that didn't. 1.7 people use it in the United States on a regular basis, and 25 million Americans have used it. I guess you can correlate that with 2.5 million for Canadians, maybe. And 26% of people who die in New York City have cocaine in their system. Wow, go figure. It's the most common cause of drug-related death reported in the United States. Cocaine, it just does a little bit, so we'll talk briefly about this to set our stage up for our hyperadrenergic system. It inhibits norepinephrine and dopamine directly. It stimulates alpha and beta adrenergic receptors, so this is an increased sympathomimetic system. And it also probably increases your systemic release of adrenaline from your adrenals. Add to that cocaine and alcohol. So if you're drinking at the time and you get ethanol in your system, it changes it to a slightly different thing, this cocoethylene. And that association of cocaine with alcohol in your system, they find is a higher probability in people that are deceased. If it's because you're drunk and high, or if there's direct physiology, not sure, but the half-life of the cocaine in your system is much longer than plain regular straight cocaine. Causes increased force of contraction of your heart, which makes your heart rate go faster, which increases your myocardial oxygen demand, causes direct coronary artery vasoconstriction and spasm, and then it's kind of neat, it activates your platelets more. So if you have more activated platelets, you have a higher risk for a clot in your artery, which can also lead to myocardial necrosis. Your risk of MI increases 24 times in the first 60 minutes after using cocaine. And we see that in bored, retired people here in Victoria who decide that cocaine's a good idea and come in with their infarcts for the heck of it, which I had last month, which was really cool. Not for him, but few effects of cocaine. The other one I'll put is, again, there's other systemic vasospastic events through other systems. Obviously, CNS can do it, and systemic, it can increase your oxygen demand. It is not just activity related. So even if they're lying still, their oxygen demand increases just because of the sympathomimetic. Finally, is the last piece for cocaine, and then we'll move on to the meat of this topic, is it can directly kill your coronary artery endothelium. And so there's a feature there of people that have been chronic cocaine users, and there's probably some recent deaths of entertainers from vascular disease that you would liken and associate their lifestyle to frequent cocaine that died prematurely of coronary artery stuff. That cocaine causing damage to the endothelium leads to premature plaque formation in your coronary artery disease. And because that endothelium has died, it scars over. It's also neurotoxic and it kills neurons. This is good to tell your kids. This kills your brain. It directly kills your brain. There is no relation between the level and the risk of death. Present or not is the relation. It's not, are you super high, super low? And it's probably that if you're exposed to cocaine, the whole system is ramped up, and becoming higher is surprisingly not associated with an increased risk of death. So, drugs are a waste of time. They destroy your memory and your self-respect and everything that goes with it. Kurt Cobain. The opposite view here is, let me be clear, I don't have a drug problem, I have a police problem. That's Keith Richards. Discuss. All right, so what happens in this? Let's talk and get to the meat of this. Take all of that physiology that we've just talked about and put it in the park at night with a whole pile of people yelling, police cars, lights, sirens, ambulances, drama around, family whose voice they probably recognize screaming and yelling at them, trying to figure out what the story is, and you have something that looks kind of like this. Something that's altering your perceptions and your agitation. Pick your stimulant drugs or pick your true psychosis. Just pure regular psychosis can do this. Those altered perceptions and agitations get you scared. It's the bear, right? Someone's trying to capture me. I'm not getting captured. And gets all ramped up as they go, which leads to this extreme superhuman aerobic activity. But all the rest of this happens. It leads to metabolic acidosis, which is hyperthermia, and both of that can lead to muscle breakdown and rhabdo. The extreme anabolic activity can give you hypertension, which elevates your dopamine, which can come from your hyperthermia, which leads to vasospasm, which also gives you muscle breakdown. When you get hyperthermic and hypertensive, you get enzyme dysfunction. It leads to cardiac dysrhythmia. The increased oxygen demand causes the increase in cardiac dysrhythmia as well. The hypertension causes it. Stimulant drugs cause extreme aerobic activity as well as hyperthermia, which also plays with a role, which messes up your enzyme dysfunction with the cross of them. And are you taking notes? I hope you are. Psychiatric psychosis elevates your dopamine levels and your cardiac dysrhythmia. Stimulants cause direct vasospasm and elevate your dopamine levels and increase the oxygen demand and also cause hypertension with the psychiatric. Okay, this is dumb, right? This is a huge amount of stupid physiology that's way out of control that we can't handle in the back of a park or sitting in somebody's car. We need to knock this person down, put them in a place that we can understand them and get a little bit of things sorted so we can figure out. It's not the restraint that kills them. It's that physiology that takes them out. And we need a better system, as we've been talking about for years, to try to hold and settle these folks down. What's bad? Here are the patients that are at risk. Guys with cocaine and methamphetamines are bad. Chronic use is more bad. If it's the summertime and it's hot out, it's also bad. Okay. If they're schizophrenic, and especially on cocaine, that's also high risk and bad. If they have cardiac or pulmonary disease, that makes it worse. Lie them prone, that's bad. An abdominally obese patient placed prone is really bad. Hobble tie or hog tie them, that's very bad. And an obese asthmatic with coronary artery disease, severe operative femoral popliteal vascular disease, eosinophilic esophagitis, idiopathic hypertrophic subaortic stenosis, and a chronic cocaine user in Florida in mid-July, hog tied to a cot, prone with a mob of 132 people. Watching is dumb. Makes sense? You end up with something like that. I don't know who that person is, but that's the best advertisement for a tombstone I've ever seen. So, when we see these guys, you run through this massive list of what's going on. And yes, we know there's going to be a toxicity, there's an excited delirium, but there's other things that's our job to figure out. Is this straight sugar? Is this neuroleptic malignant syndrome? Is this somebody with a meningitis or an encephalitis? Is this acute withdrawal? Is heavy metal exposure, I guess, is kind of it. There's a whole list of stuff that we need to get to, and you can't get near the guy where you can't hold him or take down. The vets are way ahead of us on this. They've been doing this for years. They called it periacute death syndrome. And they have multiple literature on it about protocols for how they decrease death. So, hey, look at this at the bottom. So if you take 3 big clear boxes, and in one of them you have a rat that is placed in the box and is allowed to run around, having given him cocaine, 8% of those will die. If you put a tube that's clear in that box and put the rat in the tube without cocaine, they don't really care. None of them die. You got a rat in a tube. But if you put them in the same box and give that rat cocaine and put them in the tube where they can look around and see stuff, half of them die. There's a thing there about needing to get out. I need to get out of this place. I don't know where it is. And when they get adrenergic and worked up like this, trying to restrain animals, because really we're dealing with animals, rapidly increases your mortality. So when they look at these, there's a number of these in the literature. If we were to pick when we would want to capture one of these excited deliriums, do it first thing in the morning when the temperature is low, give them a high doses of chemical restraints, and the vets have been using ketamine for decades. They blindfold them, which may not be quite as good for humans because we have more visual perception, but for animals it seems to calm them down. The vets all give them steroids, but they're vets, they give everybody steroids, and there's no science behind it. They also have quiet. Turn all of your audio stimulation down as best as you can. The animals that that have ongoing bad respirations, they all get bicarb, and then there's no science behind atropine. Don't get me wrong, I'm not advocating those last sets of things apart from maybe the quiet, but there's a message there that you're trying to find this calm, cool environment in order to facilitate the drop in their adrenergic drive. Okay? With that background set and the stage set, I'll pass the mic to Dr. Goulding and we'll talk about some of the data behind our what we were looking at in the way of the ketamine trial. And we'll switch seats here.
We've changed places so I can push the button. We lost them. What happened? Adam,
you still see
in that corner.
You still see us?
Yeah.
Okay.
At least Lionsgate does.
All right.
Okay, good. It's tough to follow on Andrew. So let's carry on. So the only bias I add here is I don't like disruptive patients being disruptive for too long, for all the reasons Andrew has just said, and then some. So let's look at. You've seen this guy before. This was January 1st, 6 in the morning, 30-year-old male, more or less, 911 call. Crew arrives. There's some history of drug use, possible GHB. He's lying there. Resps are 4. Pulse, blood pressure okay. Glucose is good. Completely flaccid lying there. Narcan is given. Very little initial response. And then, bingo, we have the wild patient. So this guy's about 100 kilos. Best guess. Shortly after this guy goes wild, 1 or 2 police units, I can't remember, arrive, plus ALS. He's restrained. This guy's absolutely wild. No IV access is possible. Midazolam 10 IV is given, or IM is given, correct? No IV access. And that's repeated. We're at 20 minutes scene time. This guy is no more calm because this drug just does not work to the effect that we want. And he's brought to the emergency department. He arrives exactly like he was. Picture a 100-kilo halibut restrained, flipping and flopping, sweating, and just completely out of control. He's screaming, help me, help me, help me. He's hot. We can't get vitals. We can't get an IV. However, we can give him ketamine. So he gets ketamine on guest weight, 4 per kilo. 4 minutes later, he's much calmer. He's agitated still, but we can get at him. He's got a RAS of 1. 6 minutes later, he's a nice -2. We quickly do our assessment, grab all our labs, get the IV started, get him over for CAT scan, and everything happens very quickly. And in fact, by 10 o'clock, he's quite a nice guy. He's awake, pleasant, and in fact is ready to go home. Excited delirium, Andrew's already talked on this, a real heterogeneous population of patients, and that's why it's hard to get a good study on them. The classic Bell's psychosis that Andrew put the initial slide up was reported to have mortality of between 70 and 80% death rate. More recently, with excited delirium, death rate varies still between about 8 and 50%. So it probably depends on what definition or what capture rate you have with them. You've seen this slide already. The unique syndrome identified a distinct group of clinical behavioral characteristics recognized in the pre-mortem statement. This is out of the American College of Emergency Physicians white paper on excited delirium a few years ago. I'll throw in a pitch. One of the authors of that is Christine Hall, one of the emerge docs here in Victoria, who is actually an international expert in this particular topic. But getting back to what do we do? Okay. These patients need containment, they need calming, and they need it now. We need to protect ourselves. But without controlling the patient, you really can't do anything, and time just flies by. We can't transport, we can't manage their airway, we can't examine, we can't get near them, we can't get labs, we can't get x-rays, we can't do procedures, we can't do anything. So they're a real time bomb. That's what this is, an old-fashioned bomb. So we're going to talk about ketamine. Now, remember when we talk about this, they're targeting the extremely agitated patients. They're violent, the dangerous, the bear, as Andrew's pointed out. And what we're trying to achieve, particularly in the pre-hospital, is not necessarily a total calming of the patient, but a calming to the point where you're able to better manage the patient, control the patient, restrain them, and begin transport. So our goal is not complete and total control of the patient, but control to your ability to then improve management. A bit on RAS scales. You guys can look that up if you're not familiar with it. Obviously, your number are quite familiar with it. But if you look at the +4, combative, violent, immediate danger, and the +3, very agitated, pulse tubes, aggressive, there's going to be some inter-observer crossover in these. One person's 3 might be another person's 4, but I think we all get the drift. And again, perfect target would be to have them lightly sedated. So let's say a -2, where they open their eyes, they'll look at you, and then they drift off in 10 seconds, not fighting restraints, but not deeply sedated. And that's perfect. But we're not unhappy with the more sedated patient, because again, in all settings, it's going to be hard to hit a perfect target. So we want to safely take the patient from a +4 to about a -1 or 2. That's our target, recognizing that there's going to be a crossover in these patients. So what about midazolam? Well, midazolam we brought in a number of years ago, and those doing who've been doing ALS for a while will remember that time when we brought that in, because we didn't have that before. Based on a number of studies looking at midazolam for sedation of the agitated patient, very good for alcohol withdrawal, very good for stimulation use, and very good for general sedation of psychiatric patients. That doesn't mean peak time. The onset time IM is 5 to 10 minutes. So that's when you're starting to see it working, with a peak around 20 minutes in duration, 20, 60 minutes. So you can see in the field how this is not the ideal agent. We're looking at an agent that's onset is only 5 to 10 minutes with a peak, when in reality you'd probably like to be unloading the patient. But it's smooth, it's safe, it's simple, and a lot of experience with this. Hence, we went to this years ago, and there really wasn't anything else back on the market. Versus ketamine, 4 to 5 milligrams per kilogram IM, and we'll talk. Maybe John will touch on this. Of course, we're guessing their weights. Probably better off targeting the 5 milligrams. Look at the onset time, 3 to 5 minutes, with a peak at about 10 minutes. With primary versus the most common side effect being some increased airway secretions. There's a little asterisk down there. Using a lower dose has been associated with treatment failure for IM ketamine. If you're going to use it, go big. I think we touched on this before. Developed in the 60s, used as an anesthetic, what we'll call austere environment. It's probably the most common anesthetic worldwide, and certainly in the vet world. Anesthetic, sedation for procedural sedation. We're not talking about that. Part of RSI for airway. Used as pain management, used in augmented treatment of severe asthma, and in fact used in depression care. So this is a pretty all-round drug. Patients who are not already agitated, so the rest of you sit on the table, if you receive ketamine, there's a degree of nausea, disorientation, and unreal feeling. This is a dissociative anesthetic. A small group of normal patients will come back to develop what we call emergence reactions. We'll talk on that later. Minor bumps in blood pressure and heart rate, which we really don't care. And laryngospasm reported in IV use and also IM use, and we do care about that. We'll come back to that. So the emergence reactions, look at that, generally managed with supportive care, tend to be brief. Benzos may help relieve that. There are some people who use benzos prior to using ketamine as a sedation agent to prevent emergent reactions. But emergent reactions are not a part of the care of extremely agitated patients. That's in somebody choosing to give you ketamine to reduce your dislocated shoulder or your fracture reduction. So a different game. We'll come back to that. So again, with the drugs, benzos, midazolam, 5 to 10 or 10 to 15 IM, standard dose range. Haldol, 5 to 10. Droperidol, 5. Olanzapine, 10. Lorazepam, 2, sometimes used in combination. But all of these have the onset of 15 to 20 minutes with that 1 to 2 hour duration. We don't need that. And 15 to 20 minutes onset in the field is not really that useful. Compare that to ketamine, 4 to 5 milligrams per kilo, with a very short onset and a short duration of peak effect. So, no large randomized style studies despite years of use. But a couple studies to comment on. One was an emergency department study, Riddle, compared ketamine versus combinations of Haldol, midazolam, Adamine. And they found the ketamine had an onset of adequate sedation in 7 minutes versus all the other ones in the 15 to 20 minute range. Cole, looking at pre-hospital, ketamine 5 per kilo, like we were doing, versus Haldol 10 milligrams. 5 minutes versus 17 minutes. There we go again. 95% adequate sedation on arrival in emergency department with ketamine versus 68 with Haldol. So they favored the 5 per kilo for management in the field. However, now this study is talked about, so we mentioned, a lot of them mentioned the hypersalivation, and I've not been seeing that, but they may be, again, one person's definition of hypersalivation may be another person's simple drooling. So I'm not really all that worried about that. This study it hits the literature because there was this huge intubation rate, 39 to 57% intubation. However, this was not in the field intubation. This was in the ER intubation, and it was all one doc on one shift.
Oh.
Okay, one particular type of shift. And in fact, I think this was somebody who adhered to less than 8 intubate, so he just intubated them all. Nobody else seems to repeat that, but that's noted in the literature. Another study looking at 52 look at the numbers, 52 prehospital patients with ketamine or ketamine and midazolam, and they noted only 2 patients required intubation. And again, I believe those were not in the field.
And both those patients received midazolam as well?
Yes. So emergent reactions. Various opinions, but maybe so many 10% of patients receiving ketamine have emergent reactions. But these are normal patients, normal in quotations, receiving sedation doses of ketamine or anesthetic doses of ketamine. And when they're waking up from their anesthetic, have this delirium or acute agitation. This is not already agitated patients who are already beyond the state of emergence. So emergence implies the patient was normal and they're waking up strange. Those patients can be managed with benzodiazepines, and some people in their ketamine sedations in adults. This tends to occur in adults or teenagers. You'll see some people giving a little bit of midazolam as part of the sedation. But this is entirely different than in the treatment of the agitated, excited delirium patient. These patients don't get an emergent reaction. Their drugs may wear off and leave them just as bad as before, but by then we have them controlled and IVs and in a controlled setting. So emergent reaction, if people talk about, really isn't relevant to the agitated patient. Briefly, Hennepin County looked at 1,800 uses of ketamine. But only 77 of those were in the violent, agitated patient. And they were tasered, and they found the same thing, about 91% effective. In their group, no further drugs were used in the field, no field intubations, no laryngospasm, no big problems. How about us? We're going to talk a little more, but as of the data that I received a day or two ago, our pilot has now done 27 cases with the expanded use of Vancouver sites. Synopsis of this, 25 of those 27 arrived in the emergency department in a sedate condition. Job done. 20 of the 27 were sedate by 10 minutes. Perfect. 2 had SATs less than 90, easy resolved with supplemental oxygen. 2 received NPAs, and 1 received an OPA. 6 of those received additional midazolam. And there's some features of the ones that weren't sedated to explain the lack of sedation.
Is there a stat on how many were admitted?
No. Okay. So what happens to these patients? We haven't delved into. It's a real mixed bag. Some of these are going to wake up if it's pure drug and go home. Some of these are going to go to ICU. Some of these invariably will die because the mortality of excited delirium is still high, and some will wake up and go to a psychiatric. So there'll be both medical, ICU, psychiatric, and home dispositions. Now, a moment on laryngospasm. So I'm saying that excited emergence reaction is not really falling into the definition of the agitated patient. But laryngospasm, now we want to pay attention to that. So in EMS case studies, I've seen one report of an adult with IM midazolam having laryngospasm. Have more occurred? Probably, because not every case gets reported, but this case gets referenced repetitively. In IV sedations, so this might be for presumably all for procedural sedation. This wouldn't be relevant to RSI because the laryngospasm is not an issue when you're following with neuromuscular blockade. Incidence is undetermined, but supposed to be somewhere around the 0.3%, so 3 per 1,000. A large Canadian study looking at intravenous sedation in pediatric 6,000 or so patients, over 3,000 of them, 3,900 were pure ketamine sedations, and they found the incidence of laryngospasm about 0.1%, so 1 per 1,000. And there's a case report that I looked at, or a case I looked at, saying that of patients receiving ketamine, 2 per 11,000 required an intubation. So if we extrapolate that, about 1% of patients get a laryngospasm, about a fifth of those, or a quarter of those, were intubated. So, laryngospasm. What causes laryngospasm? Well, there's more than ketamine in there. So, local factors. Probably the most common thing we see are both intubation and extubation of patients, particularly if neuromuscular blockade is not used. Foreign bodies around the airway. Now, here's the important. Vomit and aspiration and drowning patients will often have laryngospasm. DPNT procedures, anything gets around the cords can induce that. So we see this in patients other than our ketamine inductions, and we do see it in sedation procedures with other drugs other than ketamine. We also see it, if you drop down the drugs, in dystonic reactions, so patient a reaction to any of the Haldol type, Maxaran type, Stamatil type medicines can get cord dysfunction. Tetanus, strychnine. Periodically, I haven't seen it for years, periodically we used to see strychnine mixed with the Coke, and we'd have little outbreaks of strychnine poisoning, severe hypocalcemia, or patients with various vocal cord dysfunction. So you can get this, and when you get it with drugs other than ketamine used in sedation, it's probably because of a bit of micro regurg, a little bit of irritation of liquid around the cords. So I've seen it with propofol sedations. What do you see? Well, crowing, stridor. You might only see, if you have a complete cord spasm, you're not going to have any noise. You get a sudden rocking respirations and a bit of struggling. Apnea, and maybe very rapid descents, particularly in our excited delirium patients. These patients are hyperstimulated. They've got high oxygen demand. They're high metabolic output states. And we also, of course, see it in kids who desat rapidly. Well, what do you do about it? Well, a moment on Larson's notch, also referred to as laryngospasm notch. I try to get a nice picture of this, but I'll describe it. So put your finger on your earlobe, either hand. Push that, just put right below the earlobe, push straight in towards your neck. At the front edge of the finger, you'll feel the ramus of the jaw. And at the back edge will be your mastoid process, that bony thing behind the ear. And if you go up, it's really the base of the skull. You push vertically in very firmly, bilaterally at that spot. It's referred to as the Larson's notch or laryngospasm notch. And Larson, I think, was an anesthetist who got this technique from somebody else, and I can't remember his name. So he admitted it should be called something else, but everybody calls it Larson's notch or laryngospasm notch. Direct pressure here is supposed to, and there are no double-blind randomized trials, relieve laryngospasm. So you do this and you couple with a jaw thrust, so ideally two people. So jaw thrust, standard jaw thrust, but this pressure in at this location is noxious and has something to do with releasing it. And often there's a little pause and a sort of a pop or breath of air as it relieves. So laryngospasm, what do you do? Bag valve mask. PEEP, slow, steady pressure. Under some situations, not necessarily an in-field IM ketamine presentation, you might add some light sedation. So low dose, we might add low dose propofol if you have the drug and your wits about you. So increased sedation and or if I had it, I would use some midazolam as a sedation agent. If that doesn't work, then you have to relax the cords. How are you going to relax the cords? Well, there's a couple ways. One is talk about using low dose neuromuscular blockade with essentially a 1/10 dose of succinylcholine. There are some people who advocate that. That to me would probably be something I'm doing in a controlled situation in a patient who is not yet hypoxic. Otherwise, we go to full dose neuromuscular blockade or a front of the neck airway. So, put in perspective, this is going to be incredibly rare. You have to keep it in mind, and almost all of them will break with pressure on laryngospasm notch or Larson's notch, coupled with jaw thrust, coupled with nice, slow, steady pressure ventilations. The case that happened in the field, that resolved the patient, and we noted that very few of these patients actually end up getting intubated, at least for initial airway control. This little flow sheet here, so remove stimulus, call for help. Position, jaw thrust, 100% oxygen, and Larson's maneuver, PEEP. And then options for IV access, and you either go to full dose succinylcholine, you could choose lower dose there. You also have an IM dose, but we're sort of this is more targeted to what we're using in ER. And also an option in there, if the patient is somewhat controlled, to use a low dose propofol to relieve it. But if we look at what we can do, position, jaw thrust, 100% oxygen, Larson maneuver, and PEEP should take care of most of these. So, if you truly need control, go IM ketamine. Aim for the 5 milligrams per kilo because you're basing on the weights. And we tend to underguess patients' weight in general. I'd love to do a little study of that. But I think in general, we across the board don't recognize that there's not many average 70 kilogram males out there. We had the option of using some benzodiazepine. I would probably, unless patients would use the 5 milligram of midazolam IM if we're topping these patients up. Remember, at some point, you may get them controlled enough that you get an IV and use lesser doses. And don't worry that the patient looks unusual in the studies that reported patients being intubated, but that's, I think, due to operator unawareness of the ketamine look. Be aware of the side effects of the ketamine, and primarily the rare but tension-inducing laryngospasm. And be aware we don't need to have complete sedation. This drug is aimed at getting the patient under control so that you can manage them in the field and get into the emergency department for the further workup. And then once they're there, they can decide what to give them to keep them down, let them go up, resedate them based upon the clinical presentation. John, over to you, I believe.
That mouse there, Ryan.
Go on.
Yeah, I think I can.
You good there?
Here. Yeah, there we go. Beautiful. All right, thanks, Jim. So I'll go through this fairly briefly, basically just touching on the Victoria pilot for administration of ketamine for agitated delirium, excited delirium. We started in April 2018, and our goal wasn't really to test the, if ketamine was the appropriate drug to use for excited delirium. That's already been studied. There's lots of literature out there to support it. But there was a few things that we wanted to measure before we went to provincial distribution for our ACP paramedics. We wanted to measure the effectiveness of administration of ketamine, and we're basing that on the Richmond Agitation Sedation Scale, which Dr. Goulding had already referenced several times. We wanted to measure any need for additional adjuncts, additional medications, in this case midazolam. If any airway adjuncts were required, OPAs, NPAs, intubation, and any adverse reactions. So that's what we were looking to measure in this study. So we started out with 4 to 5 milligrams, which the literature support. This is the induction dose for ketamine, and it's the dose required to gain medical control in excited delirium. But as Dr. Goulding just alluded to, we tend to underestimate patients' weights in the field. And it was theorized that in the few cases we had where ketamine was less than ideal, we had to look at it, and we were thinking it was likely because the patient's weight wasn't estimated appropriately. And if you think about that 4 to 5 milligrams per kilogram, that's a significant difference. If you have somebody you estimate to be 80 kilos and you go with 4 milligrams per kilo, then you're giving a dose of 320 milligrams of ketamine. And if it's actually a 100 kilo patient that requires 5 milligrams, then you're looking at 500 milligrams of ketamine. So there's a big difference between 4 and 5 milligrams per kilo when you consider the variations in the patient's weight. So this is early in the trial. We had 12 patients that met the criteria. As Dr. Goulding said, we have 27, 28 now. Jim, is that what we're at now?
I believe so, yeah.
Yeah, okay. And just a quick representation of, again, this is based on the Richmond Agitation Sedation Scale. So 50% of the patients that pre-ketamine had a RAS score of +4, and 50% had +3. And there is some crossover between that. It's somewhat subjective, whether they're +3 or +4. But either way, they meet the criteria for excited delirium. And then you can see here, based on this graph here, what we wanted to measure is 5 minutes after the administration of ketamine, 10 minutes after ketamine, and then the Richmond Agitation Scale on arrival at the emergency department. And you can see there, it's pretty close to being equal across the board there. 4 or 5 minutes, 10 minutes, and ER.
John, can I interrupt? There's somebody that's got a mic on. Can I ask you to mute your mic? Sorry, John, go ahead.
Okay. There we go, that's better. Thank you. Good. So again, primary outcomes, this is measuring the patients that after administration of ketamine went from their +3 or +4 on the RAS score to a -4 to +1. So -4 is a little bit more than what we're looking for, but again, we're looking for -2 to +1. So again, you can see here almost an equal distribution. It looks like a few fewer patients were down at -4 at 5 minutes, but certainly 10 minutes after administration and on arrival at ER, they were well sedated and had medical control. And this is just a quick representation in a bar graph of what we just talked about. But you can see there the gray representing arrival at ER. And again, we don't have the time frame that represents. But you can see the 5 and the 10 minutes scores there. Secondary outcomes, again, we wanted to measure just on a scale of 1 to 5 being no effect and very effective. And on the information we have to date, 75% rated the efficacy as a 5, so very effective. And also reported that the level of sedation was adequate. And as I already mentioned here, one of the patients that weighed over 250 pounds, the paramedic was depaired, and we figured there was underdosing in the case that we had that required a follow-up with midazolam. And when midazolam was administered, they were able to gain medical control of this patient. So 50% of the time, when we started out, we were just giving 400, we were only carrying 400 milligrams of ketamine. We determined that wasn't enough, so we upped it to 5 milligrams, just right across the board. Everybody gets 5 milligrams per kilo, which again is an induction dose. It's very safe whether you're giving 4 or 5. It's negligible. Doctors, please jump in if I'm crossing the line here. But my understanding is it's not going to make a difference here. You're either going to reach that dissociative phase or you're not. And here's some numbers with the Glasgow Coma score, again representing patients we dealt with. Most of them, somewhat alert, 11, 14, 10, and one of them at a GCS of 9. Airway adjuncts, these were just NPAs and OPAs. None of the patients that we dealt with required any further airway management, ventilation, BVM, intubation, nothing of that nature. And you can see here, based on the numbers, 83 did not report any adverse effects. Just a couple that Dr. Goulding already referenced had a slight drop in O2 sats, which was just managed with supplemental oxygen. A couple of cases, 3 cases required follow-up with midazolam. And again, we suspect that was just because of underdosing of the ketamine based on the patient's weight. We're going to get, we will have more data to this coming up. We're quite interested to see where the data we have with the 5 milligrams per kilo administration and how that changes. So these are just some of the cases that we dealt with here. I'll just go through these fairly quickly. It's interesting to look at the timelines here. This patient presented with a RAS of +3, GCS of 14. And 6 minutes later, 400 milligrams ketamine was administered. That brought the patient down to +2. And then shortly after that, down to a -2. This patient had 5 milligrams IM midazolam en route and dropped to a -3 on arrival at Emerge. Here's another case, similar, presenting as excited delirium, +4 on the RAS scale. 300 milligrams of ketamine was given here. So it's a fairly low dose. Again, we don't have the patient's weight here, so it's hard to say if that was an underdose. That brought the patient down to a +3, so a marginal drop, if at all. And they elected to follow up with 5 milligrams IM of midazolam, and then another 5 because that didn't do it. So after that, the ketamine and 10 of midazolam brought him to a -3. And this last one here, again, presented as a +3, 400 milligrams was given, dropped right down to a +1. But this patient actually became more agitated, so this paramedic elected to go with 10 milligrams, which dropped the patient to a -5. And if you're not familiar with the RASS scale, that patient is virtually unresponsive at this stage at a -5.
That person was 275 pounds.
Okay, thanks. So there you go. So this 275 pounds and was given 400, so underdose again of ketamine. Quantitative data, we've covered most of this. I'm not going to bore everybody with this, mostly because I really like to open the floor to questions, because these are just some numbers. I want to give Jenny Helmer credit for this. She's been amazing putting this data together and a huge help with this trial. She's collated all this data and put it together in these reports for us, and she's continues to work with us as the trial continues. So thanks to Jenny Helmer for this. And again, here's just another representation of no ketamine, 5 minutes, 10 minutes on ER arrival, put into percentages. And again, midazolam given 5 to 10 milligrams, we're suspecting was because of underdosing. There's the one Dr. MacPherson just referenced, weighing in excess of 250 pounds. And airway adjuncts, only 8% of them required the additional airway adjuncts, and none required in 85% of them. We also wanted to track, was there adverse effects? And when we talk about that, we're referencing, was there any vomiting, desaturation, suctioning required, or laryngospasm? All we saw was just a marginal drop in the SpO2, which was easily managed. And that's it. So let's just open the floor to any questions regarding this. And before we go on, I'd just like to say as well that we have plenty of data now on the use of ketamine for this. Again, it started in Victoria with at the Central Reporting Station. We expanded it to the paramedic specialist group in Vancouver. And we are now going to expand this province-wide. I won't give you an exact date. I will say that we're working on it as quickly as we can because, as I mentioned, we have all the data we need. So we'd like to get this out province-wide to all the ACPs. And we would like to also continue tracking the data. So we will be asking the ACPs to fill out a very short, very simple data tracking sheet so that we can continue with the study. And Jenny Helmer, myself, Dr. Goulding are going to work on publishing this information. So
just going to jump in. There are no large studies of real-life experience with this available to the pre-hospital care world or literature. I mean, look at the Hennepin County one, 1,800 uses, fairly loosely reported. 77 of them are of the things we're talking about. We're quickly going to, when we expand this province-wide, be able to generate a large database. We don't need to carry on forever, but this will give us invaluable experience that we can publish and share with other services about the use of ketamine in this type of patient. So it's absolutely imperative that we carry this on, and I think we'll very quickly come up with a good and usable database that we can share with the pre-hospital world.
Good. Thanks, Dr. Goulding. So can we open the floor now to any questions at all regarding excited delirium or the use of ketamine?
Good morning, John. Andre from Lionsgate.
Morning, Andre.
Excellent, you guys can hear me. Two-part question. That's some very cool data with the ketamine. I'm just curious if we have similar stuff for midaz as far as incidence of airway use, incidence of hypotension, hypoxia, that kind of, so we can directly compare the two drugs that we are carrying?
Yeah, That's a fantastic question, and we are looking at that. So the short answer is no. We don't have a lot of that data. We are looking at retrospectively collecting that from the Form 2 so that we can do a direct comparison, sort of formulate a PICO question in this study. So that's something we are looking at doing to compare the efficacy of the ketamine versus the midazolam, but we're just not sure on how accurate that data we have from the old Form 2s is going to be. But yes, we are going to look at that.
Yeah, just to jump in, the short answer is no. Across the board, we introduced midazolam years ago. Didn't do the same degree of tracking we do with ketamine. I think universally, it was prior to ketamine. It's very rare to take an excited, truly agitated patient in the field and have them arrive. They're just like my case on New Year's Day. They receive large amounts of midazolam and arrive in a prolonged fashion. Usually in no better shape than they left. It was not a satisfactory medicine. I'd say the adverse outcome of midazolam just didn't damn well work. But we don't have data.
Cool.
And there are studies out there comparing.
Yeah, the other studies looking at it again across the board. I think about 2/3 of the patients had some sedation on arrival in the emergency department, and often prolonged scene time. So prolonged onset, 15 to 20 minutes, with at best a small amount of them being sedated. So, but we didn't do that.
Perfect. And I guess the second part of the question, we're not currently using this over here, unless you're a specialist. So I'm not sure the exact dosing or concentrations, but my understanding is for the 5 milligrams per kilo, the large IM dose, it's about 10 cc's of fluid or 10 mils of fluid for IM administration. I wonder if you guys have solved that, because that's quite a large dose to be giving to these patients.
Yeah,
Multiples. Yeah, there is a higher concentration available, but it's restricted use at Health Canada. Maybe over time with the IM use, it'll be there. We use multiple 4 cc's max, so multiple thighs and deltoid.
Mm-hmm. Okay,
so they get multiple punctures.
Gotcha.
Yeah, so, and we haven't had, it's a great point, and I think it's only the veterinary dose is the higher one that's available.
Yeah, I think the veterinary dose is the higher one available.
Yeah, so, and we were concerned about giving multiple doses. I mean, in the past, when we were with midazolam, at least in my own experience, we were giving multiple doses of that anyway.
Yes.
And I've got Ryan Deere sitting beside me, who's I think we've done this a couple of times with the ketamine, and he says it's not a big issue drawing up multiple doses of the ketamine.
I mean, it's not ideal, but it's
ideally we'd have the higher concentration, and the thing, times will say possibly if this becomes more widespread in the field, we can be able to go to Health Canada and say we need this drug for the pre-hospital use.
Yeah.
Mm-hmm. Excellent. Thank you so much.
Good. Thanks.
The higher dose would also be nice for nasal pain control, but separate.
Can you guys see us? Do you see the room, or do you see the questions?
We can see the room.
Yeah.
Oh,
Hey, it's Adam from Vancouver here.
Hi, Adam.
Hi. Curious question. What do we think the province-wide incidence is of true excited delirium? What kind of numbers are we looking at?
the key focus there is true.
Right.
Yeah.
well, again, the of extreme agitation, we've got a lot. Of the really true syndrome is probably still fairly uncommon. But there's a big enough population. There's a large drug-related population of the true syndrome. Probably half a dozen a year.
Yeah.
Here, what do we think? 30, 50?
30 in the province. I don't know what the difference between the population of Victoria versus Vancouver is. I think there's a bit of a bell curve here. There's this true excited delirium. There's the mixture of really worked up cocaine and personality disordered guys. And then there's the jerks. And I would say that a little bit tongue in cheek. That population that really needs rapid sedation and take them down is probably a small group that we're aiming for. And I think the true pH of 6.9 in the field, guys, is probably a half a dozen a year in Victoria is probably a reasonable number. So I don't know, double it, triple it in Vancouver. What's the rest of that spectrum of people that are on the edge? I don't know how far that's going to go. What I worry about is spreading it to the jerks. And the personality disordered guy that just wants to get the police to, those are the population we kind of need to back out. That's why Jim had the midazolam for that population. Yeah. We don't need to take that dude down right now. Here's a shot of midazolam, everybody back out, talk you through, and then slowly. I think 30s are reasonable, but who knows?
I think the key thing is not how much. I mean, it's like everything else. How many are meet the true criteria of the excited delirium full syndrome versus how many are RAS4 and in need of sedation and containment for rapid, safe transfer and evaluation. That's the key thing. So I don't care what their underlying physiology is. There's no other way to rapidly contain them in the field. So we're going to get, you look at this pilot, and now we're up to around 27 patients with limited uptake. There's going to be several hundred, or probably 100 or so a year across the province who require this. And there really is no other in-field therapy that allows you to contain these patients. So I think the answer is we're going to be using this multiple times. And I have yet to see, all these patients seem to be appropriate patients. And even thinking back to that, people having a bad day and just angry people who you can carry on a conversation with aren't excited delirium.
But I think that's a good point. I just want to touch, and thanks for bringing that up, Adam, because not all patients are going to require 5 milligrams per kilo of ketamine. Yeah. And there is very much a time and a place for administration of midazolam for anxiolysis, or for somebody who just need to take the edge off them. They're not true excited delirium where you need to knock them down, gain medical control as a potentially life-saving intervention. So there's midazolam will stay on CAR, and again, there's certainly a time and a place to use midazolam in place of ketamine.
Yeah, absolutely. Just jumping in there, we ran the pilot in Victoria. 6 months. 15 cases. Mm-hmm. There are more patients who were agitated who required some midazolam. So midazolam remains as an option. You now have an expanded option. We're not taking anything away. We're adding to make the world more complex, but that's the nature of it. You've got something for special events. Think of this special event drug.
Mm-hmm. No, thank you very much. Please, I wasn't suggesting about inappropriate use. I was more just curious about the sort of overall number of excited deliriums, and you touched on sort of confirmation at the hospital with things like pH. Mainly it was an intrasig.
Yeah, no, absolutely. Cool. And I think you're right. Probably my best guess is what I consider true agitated deliriums will all have plummeted pHs. And I think that was part of one of Chris Hall's studies was looking at lactates in these or pHs in these patients, and the true ones are a real sick group. Absolutely.
So you've got that spectrum of agitated person. You've got the person who's having a bad day, that's anxious and worked up, that does not need ketamine, and we can all agree on that. You've got the person who's breathing at 60 and looks like crud and is sweaty and is not agree, and we can all agree on that. It's this population where you draw that line. And those are the guys, it's the same as you can't pick. There's a RAS of +3 or RAS of +4. There's a bit of disagreement in where that goes. And how that line creeps as it starts to release, I think we need to pay a little bit of attention to that. They need something. And I'm not sure what the best definer is of which way to push that line, and I don't know if we really know. So I think we need to understand that there's a gray area here, and not come down on folks, I use this instead of that. That rationale makes sense because none of us really know exactly what that best description is in the middle of it. So I think we need flexibility with both of these two tools without having rigid, you should have done this as opposed to you should have done that. Yeah. I think in the past we've been too dogmatic about this is your indication and you're out. We need to be a little bit more generous with where that sits. Take control of the scene, keep you safe, keep the rest of people safe. And if it's just an agitated person who's on this side, but the scene is super dangerous. This is a ketamine situation, right? And where that spreads over, there's so many nuances that happen in car on the scene with what else is in the rest of the environment that'll push that line. That I think we need to be open to all of that input and what that decision making was. And I think they're all very reasonable at the end of the day.
And I think the other thing, we're going to see some cases who had ketamine who were topped up with midazolam. You're going to see some patients, I think we had some who were given midazolam thinking that's the right drug, and a few minutes later it turns out that they're rapidly escalating and they're going to get some ketamine. So it's not going to be an all or none, black or white phenomenon. It's going to be the art of sedation will remain an art of sedation.
Cool.
Thank you very much.
Good question.
Thank you, Al.
It's Ron from Vancouver also. So I'm a bit concerned about our estimations of weight. I see the same thing in the Frontier trial where we underestimate weight. And I'm wondering if we should be a little more liberal because we're dealing with a patient who's potentially a hazard to all those at the scene. And if what you've described is that we're not giving enough ketamine and we're having to follow up with Versed or whatever, I'm wondering if we should try more accurately or be a little more liberal with the initial dose. With somebody that's really a threat.
I mean, part of it is based on the literature and common practice of giving 4 to 5 per kilo. And we sort of started with 4 and moved up to 5. I'm not sure that we need to invent our own dosage range. I think the 5 per kilo seems very good. But again, part of the teaching and that's why I ran the pilot. The experiential thing is telling people, if in doubt, give more, not less. We may, as we begin to look at IM per kilo doses, we may actually get better. And this is an aside thing. I'd love to run a little trial where we estimate the weight in the field, and then have some accurate weight. And we need to have weighted scales in beds in the ER, just to 100 patients, and randomly do it and see how they correlate. Because I think medical people in general underdose gas. And I mean, from a clinical standpoint, how many times I stood around the patient with about 8 of us around the patient and say, how much do you think he weighs? And we'd negotiate the weight. Okay, this is a X. So your point is good, hence moving to 5. I don't know that we'll go more with that, but that's why we're capturing data.
We'll have some numbers. Yeah, we'll capture, Ron, now that we've moved to 5, we're going to capture the numbers and see if we have any that were sort of subtherapeutic with ketamine now that we've gone to the 5 milligrams. And we were going to add the patient's weight on the data collection form, and then we realized it's just a random number because the person's completely guessing what the weight is, so it has no relevance on the data we're trying to collect. So we'll see what if we have any problems now that we've gone to 5 milligrams.
Well, we find that it's actually, remember, it's very, very good. I mean, we're looking at getting patients sedate on arrival in the high 90s. That's what the literature suggests. I mean, nothing's a perfect drug, but so we're really achieving what we set out to achieve very nicely. And if by our guess of 5 per kilo we are still achieving it, then we're meeting what we need.
Yeah.
But I would love to just do that little study to see what weights, but we need that gear at the hospitals.
I'm not suggesting that the dosage be changed. I'm just suggesting that we need to all appreciate that we underestimate, and that maybe we should do some exercises, even in the station or whatever, or at a shift to try and guesstimate or try and determine what our guesstimate of weights are, and maybe we should all be guesstimating weights to be a bit higher.
Anybody aware of anything in the field as far as actually adding to putting under a stretcher that gets a patient weight? Is there any toy, something out there that we could? Might be digressing, but there must be something out there that a little scale that can be added to stretchers without costing $5,000 that give you a weight.
Yeah, we can also see if there's consistency as to how much we're underestimating the weight, so that we can come up with a rule with estimate the patient's weight, then add 10%.
Yeah,
Yeah,
exactly.
I
that
stand
study
at the front
needs
of
to be done, and no one's ever done that.
Yeah.
I stand at the front of all these Frontier classes I teach and ask them to guesstimate my weight, and they always guesstimate about 20 pounds less than I should be. And I thank them all. But I think, what's this an indication of? And here we're showing it again in this. So it's a consistent problem potentially.
Good point. Let's look at it.
Those luggage scales that you use.
And of course, the ketamine is actual body weight, not ideal body weight.
Yeah.
Right. So.
Yeah. He's trying to weigh his taste or
Fish weighing thing. Hang on a second, sir.
Yeah, that's a great idea.
Big halibut scale.
I do have one.
Yeah.
Sorry, I do have one quick question, if I may. So, this is Dr. Duncan, by the way. Is there any plans to roll this out to the PCP level?
Great question. So, sorry, do you mind if I jump in here, guys? So at this point, no, that there aren't any, and that's just because the only administration for this is intramuscular ketamine. So we are going to intranasal ketamine for analgesia for the PCPs, but at this stage, no, we're not looking at it for PCPs.
Okay, thank you.
Hi, I have a question. This is Sarah from St. Paul's here. Kind of in regards to that, I'm also a PCP, and I'm wondering kind of what you would like as ACPs from the PCP crew on scene, what we can prepare for you, what we can do before you guys get there. And then the second part of my question is, as a PCP who works rurally, is this a situation, if we have an extended transport time to the hospital, like an hour, 2 hours, is this a medical emergency that we're going to be asking for a helicopter for critical care to come and administer this drug?
Yeah, so great questions. So let me address the first part of your question about what can a PCP do on scene prior to advanced care arriving. And basically ensure that as best you can, the safety of the patient, clear people out, get a good history. And what we want to do before we administer any sort of sedation to these patients is rule out any other potential causes of things that can mimic excited delirium. So we want to look at, for instance, traumatic brain injuries, hypoxia, hypoglycemia, encephalopathies, anything that can potentially mimic this. So if you can get a good history from anybody, the scene, family, friends, bystanders, that might help to that. Or if you can, often it's not safe to get in there and get anything with respect to like blood pressure, blood glucose, SpO2. Sometimes it's just not possible if they're in this true agitated delirium state. But if you are able to safely do that, that's immensely helpful prior to administering any sort of sedative like ketamine. Doctors, any other thoughts on that?
Yeah, I think it's staff safety is your first piece, and then the history behind it a second. I think you ticked it all off. No.
Okay. And with respect to airback, I mean, I would almost defer to Adam there on your right. Maybe he can shed some light on this. I would say no, that this is not a patient that would warrant air evacuation. It's something that if there is ACP, ground ACP, that would be ideal. And failing that, then it's just going to be a matter of working with what you have and getting that patient to the closest facility.
Okay.
Let's get
sorry,
Adam
just wanted to say, like, in the case of when ACPs are not available, you're an hour and a half away from a hospital, the police have restrained the patient. What is the best way for PCPs to manage that if we don't have access to this sedation? Just have them on their side, manage their breathing? Like, what's the best way to do that?
Yeah, so restrain them on the cot. We'll have the Pinel restraints on car shortly. The Pinel restraints would be the best thing to use for this because they're very safe to use. And monitor the patient very closely for any adverse signs. Be prepared for vomiting. We don't know what's on board at this time. So, for instance, if we're dealing with something that's going to alter the LOC, they may be very agitated and they may lose consciousness. So watch for airway compromise, vomiting. Watch for hypoxia. Make sure they're well oxygenated.
So I have two comments. Number one, I would advocate for supine. I think lie them down their back in a position that maximizes their ability to ventilate. The other big bang for your buck is tie their thighs. Get their thighs down. These are the biggest muscles when you're along with your iliopsoas in your body. And if you're using those with a continued high energy output, you're continuing to generate pH. If you can strap their thighs down to the bed and stop the movement of their legs, I think that's better than trying to tie it down around their calves where they can get out and around from that. I think you can envision a situation, backing up before you getting them into the cot, where you've got 2 RCMP officers in the middle of a small place that are unable to contain this bear. And I think you could envision a situation where you might say, Adam, I don't know if this is going to work or not, but I think I need somebody to come and give a dose of. That's going to escalate up the chain. It's probably going to be in association with an EPOS doc, probably add the CCP crew at the same time. These are going to be aware one-ofs, and I don't think that's going to be a thing that's in the process, and they'll be a measure of managing all this. If you're in a situation that this looks like a big bad thing that's going to end up in the news with police that are super uncomfortable, there's only 2 of them, they can't get near this dude either. They're breathing at 50 or 60. They're bouncing all over the place. They're hot and they're sweaty and you can't negotiate. And the cops can't get near them. That's the population. These are super rare. They're not going to happen very often. But I would escalate that up through the PS and then the EPOS physician and then see, is 280 available? Can we even put somebody in the air? I don't think it'd happen very often. But if you're in that situation, I think it's worth going up the chain. Again, Adam, you're here. You've got gobs of experience in this, and I'd defer to you. If it was you and me on the phone and Adam says, hey, I don't think that's going to work, I'd back up and say, I think you're right, Adam. But not to put you on the spot, but I'm going to put you on the spot.
Okay, no, thank you. First and foremost, I would say I reiterate almost all of the comments that have been shared. Crew safety is sort of the number one side here. Is it going to be a routine endeavor? No, I don't think it's going to be routine. It's absolutely, within the continuum of things that could be done, but needing to recognize that there's probably going to be a protracted time between when we're called and when we can actually get there. That we need to make sure that other things are working towards trying to get this person to medical attention. I think what we've learned today from the physiology perspective, the things to be cautious of is even when we're trying to strap them to the cot per se. I love the idea of strapping their legs down, but just avoid any sort of, essentially from their belly to their neck. Avoid anything in here that can restrict that flow. The Pinels, the way that we have them restrained, they actually have straps that go around their shoulders and corral them this way so that their arms are essentially corralled, but they can't actually move. We just want to avoid any of that sort of chest constriction that can decrease their vital capacity. And then worst case scenario is, if you're dealing with that sort of bear scenario, shuttle them into that safe environment, which may be the back of a squad car. And then that whole unit now goes to the hospital, and it's like, okay, we're still making that forward progress towards the hospital because really at this point it's about your safety. I don't want to see you get in the back of the car with somebody who they're going to take down all of us. So it's like, all right, corral them in their area, and they're better in that sort of, dare I say, cage than trying to put them face down, prone, hog tie them, and corral them that way. Because they can still have some amount of movement, and then get them to where, okay, now we're at a hospital, now we have more assistance, and then drugs there. So just look at all your options. But I go back to where Andrew said, involve the PS group, involve the EPOS group, absolutely contact, and then we'll get involved there. So it's an option. I just don't see it as something that would be common.
Very common. Yeah.
These are going to be extremely rare one-off cases. Likely, if we do end up with helicopter transport, this patient's probably going to be RSI'd by the time you actually get to the actually getting off the ground. I would have a feeling. If you're in a scenario in a very small community where you have 2 police officers who cannot contain the patient, this is going to end very badly.
They're going to tase them or shoot
them. If they can get them into the car, they can take the patient en route to the hospital, because medically you're not going to be able to do anything with an uncontained patient if they can't contain and restrain. It's likely going to go a taser route. If that doesn't work, you know how it's going to go. They had one recently on the island here. It's going to go badly for the patient, at least.
7 rounds in the chest.
Yes.
No, I've subdued a lot of patients on the scoop, and it's helped me out with straps. And of course, Brian Twaits is saying use some zap straps too. So if you're having to move this patient from A to B, the scoop might be the better way to go than try and get them downstairs or whatever. But then there's a concern, as you've already identified, with restricting chest movement, and you don't want to do that.
May I make an additional comment?
Cool.
Hi, Hi, it's Chris in Vancouver. Just with respect to the Pinels and the new cots that we have and securing the thighs and the waist area, with the old cots that we had, you could easily adjust the straps in between the D-bars. So you're going to have to think a little bit ahead of this one. The new cots, the straps don't adjust that well, but a quick solution would be to grab your spider straps and just use the ones around the thigh area and just get them ready to go ahead of time, so that way you can quickly connect them. But it's just because that's what we have, and although we've been talking about the Pinels for probably over a year now, they're not on car. There's no sign of them showing up. So in the meantime, that is one option, and then the other thing to remember is one arm up, one arm down.
Great thoughts. Yeah. Great thoughts. One arm up, one arm down is a great idea too. It twists them a little bit, especially if you put the left up so they're facing towards you.
Already.
Other thoughts?
Any other thoughts, any questions, comments?
It's Ron again. The agitated patients that I've had over the years, I've had problems with spider straps. They end up in a ball of Velcro on their chest. I've gotten to the point where I've thrown them out the door in frustration. And that's where the regular buckle straps have made a huge difference. And I'm hoping these Pinels can be applied to the patient in such a way that there isn't this issue about actually securing the patient.
And you're in Vancouver. It's worse up in Kelowna, where they have this stuff called snow plus Velcro. That works really well, doesn't it?
Ron makes a good point, and the other thing is that also we are supposed to be carrying spare seatbelt straps on all the cars. So, if you've got the spare seatbelt straps, by all means, those should be long enough to make it work without resulting to the Velcro.
Ask your police and see what else they have. I know Victoria City has these ones where the wrists get restrained around. It's like a belt around the waist. And then there's two Velcros that strap the wrists to the waist as well, so it limits the amount of arm flailing. I know they had that for a while. You may find that your local police station has some other sort of body restraint device that you may be able to use as an adjunct as well.
Okay, good. Okay, good. So if there aren't any other questions or comments,
just one more, gentlemen, before we go.
Yeah.
Andre from Lionsgate again. Quick little thing about pediatric patients and sedation. We had a few cases of severe behavioral issues, self-harming, uncontrollable. One resulted in sedation, one did not. And generally, that's not well received by Children's Hospital. I'm just curious if you guys have some strategies, any experience with ketamine use in this population. And that's all.
Yeah.
No. Obviously ketamine is used all the time in pediatric sedations. I don't know that there's I haven't seen a specific body of literature, and this would be, essentially, technically peds, but not physiologically peds, I presume. So how often am I going to see this in the pre-teen, in the 8-year-old? You're going to see it occasionally. It's probably going to be psychosocially charged and a tough situation. All I can say is, of all the drugs out there for sedating them, you might make a case that in the pediatrics, ketamine is the best we have. I don't know if I can answer that. I've not seen it.
We've had 2 inquiries about pediatric excited delirium come into the paramedic specialists requesting use of ketamine.
Well, interesting. Now, I don't know if there's ever any true literature. It's an adult-described phenomena, true excited delirium. I don't know if there's ever been a case report of excited delirium in a kid. Now, a RAS-4 uncontrollable screaming and yelling kid, I think you're back to benzos or ketamine. Often we don't even know the age of things, maybe more with this. Like a lot of our drugs, if they have adult-shaped physiology, we tend to use them. I guess we could come up with a statement of, we'll go back and see, at least come up, if that question arises, statement of use in pediatrics.
Andrew, you're going to say something?
This is a tough population, and we always get fixated on this is a purely medical problem and this patient needs to come in an ambulance. And I think we need to be involved in their care because obviously their behavior disorder has got medical connotations to it. I think, again, there's a spectrum here. The 14, 16, 18-year-old kid with drug-induced stuff, that's kind of us. The 8, 10, 12-year-old behavior disordered person that doesn't want to listen or do anything to, maybe the safest thing for them is put them in the safe part of the back of a squad car and follow the police up with it. Are they trying to get them in a cot and putting you and everybody else at risk? Those 8, 10, 12-year-old kids aren't going to hurt themselves. That's rarely the situation that they're causing enough physical action to damage their head against the silent partner or something. That's pretty unusual for that to happen. So there's not I think that's an option. Those kids that you can't negotiate with and where the temper tantrum that's out of control, nobody wants to deal with, back on the squad car, bring them to us. And if you follow with or you go in the front seat with the cop or whatever that is, I think that's a reasonable thing. That 14, 16-year-old drug-associated kids, I think they're going to spill into the spectrum of this group that's going to need some of that ketamine. But these are horrible, complex calls with an awful lot of social stuff that's walking into a minefield and a bomb. And you got to be very cognizant of, I'm going to send your kid up to the hospital in the police car instead of the ambulance. There's so many lenses that this can go sideways on you. You're walking into the bomb. So I'd be leery of that police thing, but I think it's still an option for you.
Yeah, I think if it's a behavioral disorder in a kid, they're unlikely to have a medical misadventure on their police trip into the hospital, as opposed to the older
16-year-old.
What you more likely see in the more young adult crowd, where there may truly be an excited delirium and a medical component going on with it.
Wait.
Good question.
Does that an awesome concept? Yeah, we see them here at the General in Victoria, and they're often, by the time they get here, they've settled, but I've had some of them where you're not negotiating, you're not talking with this kid, and you know that's pure behavior temper tantrum. There's not anything else there, and we just give them a little bit of Ativan is what I do here. Take a bit of this and we knock them down. I don't give them the big ketamine doses.
Yeah.
They're not at risk for me, they're not going to hurt me, and they're not respiratory rate of 60, pH of 6.9.
And usually they're relatively easy contained by the police. They bring them in, and occasionally I give them benzos.
So do I. Yeah. Right. Great thought. Yeah.
Perfect. Thank you, gentlemen.
Good. Okay. Awesome. So just to summarize, well, first, thanks to Dr. MacPherson, Dr. Goulding for the presentations today. That was outstanding.
And thanks to all of you for coming and listening to us.
Yeah.
Absolutely. Thank you. And just remember, crew safety is paramount in Excited Delirium. Look after yourself. Make sure everybody at the scene is safe. And if in doubt, reach out. Remember, you have the paramedic specialists and EPOS there as resources. They're there for you to help you in these calls. So reach out to them. And thanks very much for attending.
Cool.
Fantastic. Good.